Today on the Ever Onward podcast, we have Dave McFadyen. He's the president and CEO of Trinity Health West Region at St. Al's. Dave is an incredible guy. I've known him for 20 years, and he's an unbelievable healthcare administrator, but more importantly, just one of the greatest human beings here in our valley. He grew up in Boise. He's a local kid. He attended Boise State for his undergraduate, and then has been in healthcare for 25 years in Southwest Idaho. 11 years at West Valley Medical Center in Caldwell, 10 years at St. Luke's, and now 5 years with St. Al's. And now he is the big guy, taking over for huge, by the way, shoes to fill, Odette Bolano. I can't wait to catch up today with Dave McFadyen, CEO of St. Al's. Prior to our conversation with Dave, I'll do a Alquist update with my partner, Holt Haga. Holt, we had a little topic to talk about an Alquist update.
I think it's important. Yeah.
It plays on a sensitivity that I have, which, listen, I'm in an office with all these killers and young guys that are in their early 40s, and I'm pushing 60 now. And so
we're all getting old, man.
Sometimes I get sensitive, Holt, and I just poke my head in your office, and I said, man, you young guys don't listen to us old guys anymore. But I will tell you, like it's a quick story, but when I was training in emergency medicine in Tucson, Arizona, one of my attending physicians was Frank Walter. Yeah. And this guy's a legend. He is by far and away the just kind of sheer intelligence, one of the smartest guys you've ever been around, and he would school you on everything. I mean, every moment was a teaching moment. And when you would go to present a patient to him, because in the ER, what you'd do is you'd go see 2 or 3 patients, and then as a resident, before you could start a treatment plan, you had to go find Frank, Dr. Walter, sit him down and say, hey, this is patient A, this is what I want to do. And most of your attendings, like most of them would say, great, go for it. They wouldn't even, half the time you think, are you even listening to me? And Frank every time would look at you and say, wisdom comes from bad experiences, and bad experiences come from lack of wisdom. Let's go see the patient. Yeah. And as a resident, it would piss you off because you'd like, hey, I've got this person in here that I think's got this easy thing. I just want to go treat him. Yeah. And he would walk in the room, and you'd walk with him, and half the time you're rolling your eyes like, okay, here we go.
Let's go through it. Yeah.
And then when he walked in the room, he would start off the same way. How are you doing? And he would kind of do his thing. And you know what? Man, I learned a lot.
You learned a lot.
Oh, I learned a lot because I'd like, I missed that, or I didn't ask that, or man, why did he? You know what I mean?
Yeah.
And so, I just think about that a lot. And as I've gotten older now, I'm like, hey, wisdom comes from lack of experience. And in whatever industry you're in, having your kind of head on a swivel, looking around, saying, hey, what is there to learn here? Especially as our economy's changed so quickly and the technology's changing now, is what can we learn from the past to help us? Anyway, that was a short way of telling you that the other day. I was feeling a little
well, and I think I don't know, younger guys. I hope is like I think our generation still is like we're students. Like I've attributed a lot of my success just to learning. Just you're always learning, right? But I just thought it was an interesting comment because I see it, and I hate to point the finger at the generation below me because I'm sure it's my generation too, but the value of learning from guys like you, Tom. You've been like an incredible mentor to me and everybody else in the office.
We made a lot of mistakes, right?
Yeah.
I mean, you learn, and they're deep.
Yeah.
We went through the Great Recession.
Yeah.
You were still like,
I was still skiing. I think I was skiing a mogul run in Park City.
You were still on the U.S. ski team, like. Having to spend your, time in Argentina.
I wasn't in the fetal position under my desk.
And so you go through that one, and then you go through, this last one. It's been very different, this last kind of slowdown, but you go through those and you learn a lot.
The message is important though. Yeah. Like it is, because it's so easy to sort of, to not understand the value of the guys who have been doing this for a very long time. And I'm more talking to the young, like the crew that's early 20s trying to figure out what do I want to do.
Are you starting to feel like an old guy?
I'm feeling like an old guy. 42. So I think I am one of those old guys now. But
do you know how mad that makes a guy that's almost 60? Having a guy like you say you're feeling old. Anyway.
But I just want to say, because I think it's important, because I see it every single day, is that when we look at a lot of projects. Let me just give an example of this. So we look at a lot of real estate, right? A ton of real estate. And I was on my Google Earth the other day, and I was deleting all of our pins, all the pins that I had. And I'm like, well, we didn't do these projects, so I deleted them. I deleted like 30 pins. I'm like, wow, we looked at a lot of stuff. And those are things that we actually really looked at. There's all the other things that we look at and just pass. But when you look at a piece of real estate, and it's part of the reason, it's a large reason, part of the reason that we're so successful is you can look at a piece of real estate, Tommy, and leverage on all your experience. Yeah. And in 5 minutes, you can back of the napkin say, this project works or it doesn't. There's always the landmines and the claymores that'll happen with design. And then on the ones
we think are going to work, then you're like, okay, now where are the other landmines, right?
Where are the other landmines?
But you're kind of constantly saying, okay, what are you're thinking with the end in mind, right?
Yeah.
And you're backing in pretty quickly to, okay, what are all the things that need to make this thing work? Yeah.
Yeah. But the young, like, unless you have that experience, you'll go chase this down.
And what we're experiencing right now, like this week, I've probably had 3 different people in here that are young folks that have gotten into trouble, that have come in and said, hey, do you want to take over a project, right?
Yeah.
And I sit down with them and I understand how it happened.
Yeah,
I get it.
You're like, here's where it started.
I completely understand it, and some of them might give us a chance to kind of partner and help out, and some of them you're like, hey, man, it's going to be a tough lesson to learn. But your point's very well taken, which is, and you know what, there is no replacement. The replacement for developing wisdom, if it's not bad experience, is listening. Yeah. Those are your 2 options.
Yeah, right.
Frank would tell you that, right? Dr. Walter would say either we go have a bad experience and you learn, or you learn something from me. And man, wherever you are, Frank, love you, man.
Your lessons have
it's been great. Thanks, Holt. Thanks, everybody.
Thanks, Tommy.
Dave, thanks for coming on.
You bet.
This will be fun.
Yeah.
It's been a little while.
It has been.
How are things out there?
We're moving and shaking, changing the way we're doing things and trying to adapt to what's coming at us.
I honestly can't wait till we've been kind of heads down and busy in what we do, but healthcare, I think with change in the administration and then challenges here locally, is it just crazy right now?
I think healthcare is always somewhat crazy.
Yeah.
We're adapting
it always has
to
been, right?
Clinical environment, changes in policy, changes in
reimbursement,
new technology, reimbursement. But it feels like it's moving faster than ever.
Yeah.
Yeah.
What do you see as some of the biggest challenges you're facing right now?
I think adapting to the new legislation, both at the state level and national levels, can be key. Most of that won't roll out for 2-3 years. And so we're in the phase of learning. What does this mean for Idaho? What does it mean for healthcare?
Can I ask? So one of the questions I've been dying to have you on to ask you a couple questions, because if you go back, I'm old, Dave. I've been doing this a long.
I'm not far behind you.
I've been doing this a long time, and you go back in what I would, as an old guy, call it the good old days, where you had a doctor and a patient relationship. It was really pretty straightforward, right?
Yeah.
I mean, when in the 90s, it was pretty straightforward. You had very few layers between the provider, the hospital, the surgery center, wherever you're getting your care, and the physician, and there was a lot of real accountability. I go back to my days. You had a paper chart, and at the end of the chart, you would lift it up and you would list out the things you're billing for, and the physician. I would do that, right, and then I would turn that in, and I was very tied to billing. I knew what was going on. I could have a patient come in and tell me, or what did happen. We had professional courtesy, we call it. So if you had a fellow doctor that came in with their family, you could say, hey, I want to write off my services. And I knew exactly what it was costing, right?
Yeah.
And then there was this transition to where it got bigger and it got harder. And then Obamacare passed. And when it passed, I remember having lengthy discussions that, does this really fix much? Because it really didn't go socialized,
right?
Where you kind of had a 2-tiered system where the government just kind of came in, and then you had private insurance. And it's a misconception to everyone that thinks that, like, if you have socialized medicine, you just have socialized medicine. In every country that has socialized medicine, they have 2-tiered system, right?
Absolutely.
They have private, not. But when it came in, it kind of went down the middle.
Yeah.
So then you had, PBMs on the pharmacy side. You had all these intermediate things that happened on the medical side.
Right. Complex.
Complex.
Yeah.
And so then you had this, what I would say is this bloating of kind of like regulation that kind of came in. And so now it got really complicated. Then there was this hope for me, because then you had like value-based care. Right. So then shoot, it's probably been 10 years for this.
At least.
Yeah, you go back 10, maybe 15 years, and everyone's like, hey, we're going to change the way we do healthcare. Because long time ago, when the blues started, it was, first time insurance was introduced, fee for service. We have this revolutionary idea where we're going to have this, we're going to pay people to keep people healthy. And that was the whole new thing. And it's this value-based care thing, and it's complicated. But if you take care of patients and if you check all these boxes, then and their outcomes are good, and it all sounded great. It was really hard to do, though. I mean,
it is hard.
was really, really hard to do. Sounds good, but then it was kind of like I describe it like you got your feet in two canoes, because you still have a whole bunch of people over in this canoe that are fee for service, and you got a whole bunch of people over in this canoe that are value-based care reimbursement, and you're trying to figure out how to do both. Right. But I thought, at some point we're going to transition and get out of that, and then what? Because it seems like we're in the then what, but
we're still there.
We're still there.
Yeah, and I think we're trying to figure it out. What I'm excited about, though, is I think value-based care and the premise behind that is still real. How do we take really complex patients that utilize a lot of healthcare and cost a lot to the whole system? How do we keep them out of that environment? Yeah. And so, at St. Alphonsus, we are standing up clinics with extra resources and identifying those patients, whether they're commercial or Medicare Advantage or Medicaid, so that we can redirect them to these clinics where they may be seen 3 times a week.
And but your whole goal is, hey, let's keep these guys.
Keep them out of the ER. Keep them out of the inpatient setting.
Because when you look at like a patient, like let's say you have a 5,000 employee company. At the end of the year, you can get. I remember when I helped it was not West Ada, it was a Meridian School District back in the day. Yeah. But Linda Clark and they pulled up it was blinded to who the patients were, but they pulled up the consumption of healthcare. It was shocking to me. It's the first time as a doctor I'd ever looked at like a very big organization, but it's really 5 to 10% of that panel that eats up 90% of the healthcare.
Potentially, yeah, at least 80. Yeah, it's incredible.
And so the idea
so we can't stop that.
The idea is you keep them healthier, and it helps them. Right. In theory, it should be good for them. So what are you doing?
So what we're excited about is we think about, and it's newer for St. Alphonsus. Over the last couple of years, we've been wading into taking on that risk or value-based care models, and so one of those things is making sure as we bring on those panels of patients, understanding who's in that 5,000 panel group. Yeah. Identifying those patients and working with them to get them into these clinics. And the first clinic will open up in Caldwell this fall at our new center out there on the freeway. Beautiful. So really excited about that. And Dr. Yakeley is going to help us with that clinic where we have pharmacy, case management, social work, resource managers that can help them get the kind of care they need. Do they need pharmaceuticals? Do they need housing support? What's their access to healthy foods? So all those things that we can try over time go from 3 visits a week down to 2 and eventually down to 1 and then monthly. It's amazing. And that's what we want to do.
Hey, and I think that's good for the community. That facility's awesome.
It's beautiful.
I hadn't seen it for a few months. Yeah. And I was out there. We have everything right next to it there at North Ranch, and I'm like, oh wow, that thing is coming together. It's coming together. It looks so good.
It's a footprint we're going to use, that same model.
Okay.
And so we have urgent care, primary care, specialty care, imaging, and lab. And we're purposely not putting in an ER. We want urgent care. Yeah. How do we develop centers that are low cost, close to home?
So smart.
And we have this vision. If we're within 10, no more than 15 minutes where you live, that's ideal. And so that center is going to go in. We have another one planned for North Meridian out towards Highway 16, that new development. Another one in South Meridian. And then really filling in the community with access to primary care. Because the last thing we want to do is drive patients to ERs, drive patients to inpatient care. We want it close to home and affordable.
And in theory, Dave, I mean, like that's always been the hopeful model, right?
Right.
I mean, I think when we started Salzer, then that was kind of we bought it, and then that was part of the plan, and it just didn't ever happen. But that makes a lot of sense, right? Yeah. Having accessible health care to primary care, keeping people healthy, the whole idea, it's become harder. How hard is it to access care right now? Do you know within your system?
We have pretty good access. I
you?
think the challenge is if you want a certain provider in the primary care side, it may be harder to get into certain ones because their panels are so full. We have enough new providers that if you want to see a primary care physician, we can get you in.
Oh, good.
Navigating that is still a challenge. And one of the things we're doing is creating a new navigation system.
Good.
This next year, you and I are the same way. You have a friend,
Yeah.
I can't get in, well, you call me.
Yeah.
And I can make a few phone calls, help connect people, and we get them in. And so we want to create that same experience for any patient in the Valley. One number, call this number, and we'll help get you in, and we'll navigate that for you. So that's in design and development too.
Isn't that one of the I think as well, part of it is just dealing with growth.
Mm-hmm. Incredible growth.
And you have, if you go back 20 years, we were already talking about 20 years ago, physician shortages in Idaho. And then 10 years, it was getting worse. And so you think about, you are already challenged in Idaho for primary care. Right. It's just always been a need. And now you have this explosive growth. But by anyone's prediction, no one ever anticipated this. And now you just have Micron. I mean, it wasn't just the first time. Now it's the second one. And
another wave.
I think everyone just like, what does this mean to us, right?
Yeah. It's exciting and a little scary.
Oh, it's really exciting, but very scary. That's great. And so I think you've seen. I might have people call me all the time. Hey, can you help me get in here? I've called. I can't get in, or whatever. And I think some of it is navigation, because I think if they get pointed in the right direction, then it works. But it's like sometimes just. So I'm really glad you're doing that. Yeah. Tell me more about that.
So that's step one. Creating the access.
Yeah.
If I can, pivoting back to the physician supply. So here in Napa, we're opening up our first GME clinic.
Oh, great.
We're post medical school, going into residency, and so we're gonna have 6 residents starting July 1 in Napa. Plan to get to 24 residents over the next couple of years.
I didn't know that. That's fantastic.
And the really exciting thing is 4 of those 6 came from ICOM right here in the Valley. And so keeping our students here close to home, building a pathway.
Well, and people don't realize that residents stay where they train.
So critical.
I don't know what the percentage is nowadays, but it just makes sense that you fall in love with the community. You're already building your family, your life. You have this known thing. It's so
critical.
It's critical. It always has been.
And
critical.
I think we're usually 50th, 49th in the country. For primary care.
Yeah.
So we have to do this.
Yeah.
So really excited to get that kicked
that's
off.
Great.
Yeah. And it's good for local kids. And as we work with the legislature, we got to make sure we have a good DO program and a good MD program in the state, and creating the residency slots. We can't just have medical.
How has the legislature been in receptiveness to medical? Well, a couple of different buckets I'm going to ask you, and I know we're going to try not to get. But like, do they understand the medical education, lack of primary care, lack of access, or have they been helpful?
I think we're trying to educate, and it's a complex system. Yeah. And I think a lot of elected officials, if you don't spend time there, don't quite understand how it works. How is the DO school different than MD? Yeah. How do the slots work? What does that mean when they go to residency? And so I think through the committees that the governor has helped stand up, and the right experts, creating the right documents, the right white papers to help educate is key. But we have a lot of work, I think, to still do there this next year to ensure that when they make a decision around funding and partners and those things, it's connected to what's going to help Idaho retain future physicians, because we can't just have medical schools. If we don't have the residency slots, they'll go to medical school, and like you just said, they're going to go off to residency somewhere.
It's actually more,
and they won't stay.
It's more important, actually.
It is.
Like if you didn't know how it worked, it's actually like in the level of critical need, it's above it.
It totally is.
Yeah,
I agree. Yeah. Well, you think how it is, right? You go to residency, meet someone, start a family. Yeah. You like where you're at, and you don't move.
Yeah. Well, that's great. And so then I don't know if you know all of the implications, but how, with the big beautiful bill passing and what it did to Medicaid and work requirements, have you guys already drilled into what that means for Idaho?
We're still assessing.
Yeah.
I think our initial assessments, there's different parts to the bill that we still need to unpack, but a few key components. One being that our state just decided to go from a value-based care model for Medicaid to a managed care model over the next 3 years. Our legislature voted on that. Couldn't be worse timing, because with that change, those payment mechanisms from the federal government changes between a VCO model versus the Medicare managed care
I'm
model.
just sitting here thinking about how, I mean, that is a dramatic, that's like taking the Titanic and saying, go the other way, go the other way.
Yeah. So
Because you've been planning forever the value-based model for that patient population, which is a high-cost patient.
yeah. And there's several $100 million that comes to the state of Idaho from the federal government to help offset the losses in Medicaid here in the
Yeah.
state, and that gets dispersed across rural hospitals to hospitals like St. Alphonsus. In the new model, under managed care, insurance companies will take accountability for managing those lives and then working with us. But the payment mechanism from the federal government will change under this new bill. And Idaho, I think, will lose more than any other state in the country that we can tell based on what happened there. And so unfortunately, they didn't, at this point, address that for Idaho. So I'm not sure where that's going to land yet. We have to see. Based on just today's model, we expect St. Alphonsus could lose $35 million a year in funding that comes in to offset Medicaid.
Just because of a funding mechanism change.
Yeah, and like I said, that's a really early number. We got a lot to unpack.
But whatever it is, the point is that these decisions make huge impacts downstream.
Yeah.
And you're clipping along just trying to take care of people.
Right.
It doesn't change how many sick people are coming to you.
And people think that's just money coming to the hospital through a check. That $35 million is not just that. What it is those patients in Medicaid expansion that won't have coverage in the future. So what's going to happen is they're not going to see their primary care doctor. They're going to wait longer, eventually end up in the ER, be really sick, don't have access to meds. And so then there's going to be this really big cost of care for an inpatient stay, ER stays. And we're going to have to just write that off. It's a bad debt. And so that's where that loss comes in. It's not like it's just a check coming from the federal government for Medicaid reimbursement, right? And
the other thing that's always been interesting to me with like indigent care or whatever, it's like you pay for it now or you pay for it later. You're never eliminating the need to pay for it. It's just how you're going to pay for it, and the sooner the better. I mean, you would think the other thing, I haven't listened. Well, the Robert F. Kennedy thing's been interesting for me because I'm like Western ER, right? Neanderthal, and a lot of the stuff when you first hear some of even the medical stuff he talks about, and I think still some of it is kind of out there, but a lot of it, and then you go back to his thing on wellness and all this. So I think going in, I'm hopeful that someone might be able to go back there, but the issue is you've got this machine, right? This thing that is just cranking along, changes. Have deep implications that affect people's lives today.
Right.
And how do you make adjustments that don't have unintended consequences or unforced errors that are potentially very difficult to overcome?
Yeah, I think really what's happened with this bill is it's pushing all of that back to the state level. The federal government's pretty much saying we're out of funding Medicaid for that expansion population for the most part, right? Those that really need Medicaid are still going to have Medicaid. Yeah. And so the states are going to have to figure out
what to do.
What do we do? And in the past, even here in Idaho, before Medicaid expansion, the counties had county funds, indigent funds. Those all sunset, right, as we went to Medicaid expansion. So
let's talk a little bit about that. The way it always worked is counties had some funding that came from the state.
Multiple levels of funding.
Yeah, and it was just, they... And by the way, there was a ton of pressure on that. I don't want anyone to think like there was like these excess funds.
That wasn't easy either, yeah.
But at the county level, they were making decisions, okay, how are we going to use these indigent funds to help our little community hospitals? I mean, I would sit in those meetings like with those rural hospitals and go, oh my gosh, how do you make this work? So it was not like you had excess dollars, but those funds are now gone because the Medicaid dollars came in that said, hey, now this is how we're going to take, again, you're just shifting the way you're taking care of the same patient population pool.
Absolutely. Yeah.
Wow.
Yeah. So, a lot of work to do the next couple of years. I do believe, though, and at St. Alphonsus, we're committed to this. If we focus on the right things, we'll figure that stuff out as we go. And what I mean by that is we have high acuity specialty care for when you really, really need it. So you don't have to travel to University of Utah or UW. That keeps people close to home. That lowers the cost for the insurance companies, right? And so we're focused on that. And then these access points we're talking about, that's going to be key to creating that right care continuum with the right cost structure. And then I think as we partner with the state, we have to partner to solve this. It can't just be us against them. It has to be us getting creative and finding solutions. So I do worry for critical access hospitals. I think, the large systems have more ways to help manage some of that risk. Yeah. It's going to hurt, and it's going to slow down new services or investments in certain areas. But critical access hospitals are already just right on the edge.
Let's talk a little bit about that. So if you go back to the way hospitals are funded, they get reimbursement rates for Medicare and Medicaid that are federally, and then there's these fee schedules that it's supposed to help price fixing, but ultimately you end up with these master fee schedules that have to be driven by something, and they're often driven by these federal rates. That's probably, you tell me when I say
Close
something
enough.
that's completely
that's close
off.
enough.
And then what happened is in critical access hospitals or rural hospitals, they already have a hard enough time keeping their doors open, and they are critical. They're critical in a lot of ways. The name is, I mean, you've got these little hospitals that feed, healthcare to a lot of people. That the one I'm most familiar with, when I tried to go, when I started going part-time from the ER, I would go to Weiser Memorial.
Oh, yeah.
And I worked there for 3 years. I do a 24-hour shift on Fridays.
Yep.
That was and I thought I could do this forever, and then I realized I couldn't, but I loved it. But that's a critical access hospital, so I know a lot about that one. But they would get reimbursed at 100%, right? That was their deal, right?
Cost structure.
Of cost structure.
Yep.
And so that was helpful to them. But even with that, it was always hard, right? It was always
Just right there.
right there, like they're on the edge always of how do we stay open and how do we provide these services. And so your point is, like, any change, it's a big problem for you because changes are hard. But if you're a critical access hospital that was already on the edge, it does not take much to.
Not much. 1%,
Is that
half
accurate?
a percent.
Yeah.
Absolutely. I mean, so we have a Baker City as critical
Yeah.
access hospital in our system, and same thing. I mean, we usually are either right at break even or losing a little bit.
Yeah.
And we've made tough decisions out there around closing services. OB was one of those, a couple of years ago, and especially as we came out of the pandemic. And I'm committed to trying to find a way to try to bring back those services. I think if you live in these small communities and you're 2 hours away from a Boise or 5 hours away to a Portland, I can't imagine not having access to basic services. And so we're committed to trying to figure that out.
And to be clear, one of the things that I sometimes I get in conversations with people, and I'm like, well, you wouldn't know this, but we're talking basic services, right? Because the system's already set up from Baker. If you come in and you have a heart attack, you have a stroke, you have something that's serious, you pretty much get stabilized and get air transported to higher level service. So that's already built into the system. We're talking just basic stuff that
Basic general surgery.
Basic general surgery.
Delivering babies.
Delivering,
ER.
Yeah, just basic stuff.
Right.
And I would say from the ER, like all my years there at Weiser, I'm guessing a little bit here, but probably once every other shift, I would have to fly someone out from the thing. But most of the time, we took care of with that little community almost everything that came in somehow, some way. So you go back to cost. And why I like bringing it up is think about that. You've got it was just a little teeny ER. With a little teeny community of physicians, but you were taking most of the problems that happened in that catchment area and saying, hey, we're going to figure out how to take care of these patients and do it amongst ourselves. That's very different than if you don't have those things. And now, one, it's people are not going to get care. So those things that they just get, they're
going to wait too long.
Most healthcare problems, like a urinary tract infection in an older person, a skin infection in an older person, the longer you let it go, the harder it is to treat and the sicker you get, right? So we'll take diabetes. I mean, you take any illness there is, hypertension. It is primary care, it is prevention, and then it is having early access to early treatment that ends up dramatically reducing costs.
Reducing the cost. Even in small communities.
Even in small communities.
If not more important.
Yeah, if not more important.
Yeah. So we're committed to that, but we got to have partners with our physicians as well. So a lot of work happening out there in Baker City with our family physicians, because family doctors, they practice inpatient medicine.
Yeah.
They practice in the clinic, sometimes in the ER, sometimes they do endoscopy. And if you don't have them, then you got to fly in a hospitalist, internal medicine doctor that's just there for a 12-hour, 24-hour shift, and that's expensive.
Yeah.
And that's not somebody that lives in the community. I love the family physicians in our rural communities.
Yeah.
Many of them grew up there. They're part of the community. You see them at church. You see them they're out playing soccer with the kids.
I will tell you, and this is going to sound like another old guy thing. I don't know why. I'm on this old guy kick. Maybe it's 'cause I'm almost 60 days.
Yeah.
But it's like I remember when I came out of residency in the 90s, right? And we would. Well, first of all, I would moonlight a lot because when you're so poor and you're just like
coming out,
someone will pay me $50 an hour to go. You'd go where I work my tail off. But these grizzled family docs, male and female, that just did everything. You would go from you're just these people that was their life. They took care of people, and come what may, time of day, and it just always blew me away. I was like very humbling, like, Doc so and so, it just does everything for everybody.
Yeah.
You don't realize as they age out, you get a new breed of doctor coming in with one, they probably weren't from the community. Two, they're not signing up for 80-hour weeks,
Right.
60-hour weeks.
Yep.
And so it's not a one-to-one replacement for those folks.
No. And I'll go back to the residency then.
Yeah.
It's so important that we have residencies in the West
So think about this, yeah.
with individuals that want to live that lifestyle, especially in the
And we
especially in the rural setting.
keep our own.
And keep our own.
You're more likely to have an Idaho resident that goes to an Idaho school, and then most importantly, an Idaho residency
Right.
that then stays in an Idaho community that's irreplaceable.
Irreplaceable.
Than having someone come in from outside that's here for 2 or 3 years and leave and kind of bounces around. It's
Yep.
recruitment and retention.
Totally is. And in Baker City, I think half the doctors out there either lived there or grew up there, and they came back.
Yeah.
To care for that community. And so, and you're so right. In the larger settings, we're having to go to shift work because the doctors don't want to work those long shifts. They don't want to be on call at the end of a long clinic day. And so, that's adding cost to us. We're having to adapt to the new physician models, and it's also creating shortages.
Oh, yeah.
Right? Because in the past,
Just a numbers game.
it's a numbers game. Yeah.
Gosh, we jumped right into it,
We did.
which is fine. You're a local guy, man.
Yeah. Yeah.
Grew up here, stuck around, and I know you spent like 10 years at West Valley, is that right?
About 11 years.
11
About
years at West Valley, and then some time at St. Luke's,
About 10 years almost, yeah.
and that's where I got to know you pretty well there. And then when you went to St. Al's, but you've like been, Dave, let's be honest, man, you've been like this rising star that everyone's like, I wonder where this guy going to end up. And then you end up going over to St. Al's and working with Odette,
Yeah.
and then like trying to fill those shoes.
Following those small shoes. Big, small shoes.
Yeah.
Yeah.
I had like the total privilege and honor to getting pretty close to her and consider her a dear friend and mentor, and you get to come in and take over for her. So how's that been?
It's been incredible. And, just backing up for a minute, it's been such an honor and a privilege to get to serve in a community. And, I've always had this passion for healthcare. My dad was in the hospital a lot as a young kid, so I feel comfortable in hospitals. So I wanted to somehow end up in healthcare. I thought I was going to go the clinical route. Wasn't the right fit for me. My brother's a NP for a pulmonary group over in Bend, Oregon, so we both have kind of that passion. Never thought I could do it here locally. Was at West Valley, and an incredible learning experience. They're part of HCA. They know how to operate hospitals, and thought I'd have to move around the country, and had this opportunity to go over to St. Luke's at one point, which was a great experience too. I've got a lot of friends over there, done a lot of good work. Thought I was leaving the community again right before the pandemic, and I love telling this story.
When were you at St. Luke's?
So I was there, I think I started right around 2010, 2011 through 2020.
So you still had Jeff Taylor.
Oh, yeah. Gary Fletcher, Jeff Taylor, John Key.
Was Gary still there?
Gary's still there, yeah.
Yeah, man, I have
good
such
guys.
fond memories of, how it might be too nostalgic. They may not be as awesome as I think they are. But like, I think back to you got Gary Fletcher. Like
Icon.
Icon, Dahlberg, and then Jeff Taylor. Jeff Taylor is kind of like the Wizard of Oz.
Absolutely, yeah.
He really kind of is. He's
not your typical CFO.
and he's super humble, behind the scenes. But you think of all the stuff, and you got to work with all of them. By the way, I've tried to get him on this podcast, and he's
Get
like,
him over here.
He's like, I'm like, I can't do that. I'm
Yeah.
like, so you got to have to twist his arm. So you're with those guys.
Yeah.
And then
Learned a lot. We built a lot of amazing things.
Yeah.
And good things for this community. And so I thought I was leaving. It's been 10 years.
Yeah.
And I wanted to keep growing in my career, and thought I was going to leave again. And my wife didn't want to leave. Right? She's got roots here. I got roots here. Both went to high school together. That's how we met.
She went to high school here too.
Yeah. So we went to Boise State, NNU. We've been all through the valley, and we love this area.
Yeah.
But it's tough when you're trying to grow a career. Yeah. And so she kept telling me, call Odette. And I'm like, I can't call over to Odette. That just doesn't feel right. So finally on a Friday, I was like, if you'll leave me alone, I'll call Odette. So I called her, and Andy Costantina, who had only been there a year running the Boise hospital for them, had just given notice. And it worked out great. It was a God thing in a lot of ways, because Had I left in February, March of 2020, going into the pandemic, which I had no idea was going to happen, would have been awful for my family. And so getting to stay local and work with Odette was just an incredible opportunity. And, Odette and Chris had a great relationship.
Yeah, they did.
And I think me coming over too, I've known Chris and that team over there a long time. I feel like really good relationships. And throughout the pandemic, that was key, that we partnered and took care of this community.
And to be clear, it wasn't always that way. I mean, there was like some serious rivalries. Like I remember when I got here in the 90s, and like shortly after I got here, like all the neonatal docs all picked up and left, went over to St. Al's at one time.
There's been some shifts.
There was already cardiology stuff going on. So it's nice that in a community like ours with only really two major, HCA has been very important in Canyon County, but it's the two of you that there is a relationship.
Yeah. And it's important.
And that was great. Like during the pandemic, the collaboration was really impressive.
And that's what we need. We have to compete.
Yeah.
That's important. But we need two healthy health systems to care for this community. So that's in a good spot. But what an opportunity, though, to work for Odette. She's an operator through and through. And she was the right fit for St. Al's for this community during the pandemic. And for all of us, we worked good 18 months without taking a day off, whether you're administrative or physicians. It was an incredible time. But I saw so many around us rise to the occasion and just do what was needed. So, yeah, like you said, great opportunity to work for Odette. Wasn't sure I was going to step into the role, or wanted to even apply for it.
Tell me about that. So she's before we leave her, tenacious leader.
Absolutely. A lot of drive.
It was super awesome. Because you meet all sorts of people that you look up to that end up being your mentors, and they all have different qualities. But like I learned a lot from Odette.
Yeah. Yep.
And mostly just kind of this fearless confidence of just, hey, I'm going to do the right thing.
She knew how to cut through it.
I'm going to cut through the BS, and I'm going to do the right thing all the time.
And not just in the hospital.
Yeah.
She was on various boards, served in the community, and same thing.
Yeah, it was.
Made an impact.
And humbly confident. Didn't, it's kind of like one of those lead always, use words when needed. Just really, really learned a lot. So that had to be incredible. But then she's leaving, and you apply. Yeah. How's it been?
It's been great. We're very different leaders.
Yeah.
The things her and I really aligned on and connected on was operations. Running really efficient, high quality operations in the hospital. So that was fun to work together on with her on those things, and we did that, and we have that base already. Me being a kid growing up in the community, my focus is shifting a little bit. We got those operations. We have high acuity care, but it's all that stuff I just spoke to earlier around really creating access at a low cost point for our community and partnering with payers and businesses to figure out how do we do that for this valley? Because as you know, the cost of living is just going through the roof. And so if you're in that middle income to lower income, it's hard just to have housing, put food on the table, let alone figure out your health care. And so I want to try and help figure out how to solve that. There's lots of factors besides just government payers. We've got rising costs, tariffs, inflation, wage cost pressures. But I'm committed to trying to figure out how to do that.
Everywhere.
Yeah.
Yeah. Well, I commend you. That's if you think about a family budget, right? And just here's a story from yesterday. We started a little thing with Operation Military Blessings. We do a lot with them. And Tom Westall is an unbelievable guy, but he found out that they were very short on diapers and formula for the L1, the level 1 military families who are, 39% of them are food insecure. Like, think about that. Yeah. But so we had this little press conference here yesterday, and I told Alex, I said, hey, go over and grab some diapers and some formula for the table. And she came back, and I said, how much was that? And it had to be she's like, it was $400. So my point is, you think about diapers, formula, food, car, just the inflation we've had, and then on top of that, you put healthcare costs. However, you're trying to figure it out as a family. There are a lot of pressures. Right?
There are a lot of pressures. That young family, the kid's out the baseball field, falls down, whatever happens, you end up in the ER. That's a $2,500 to $3,000, $3,500 bill. Urgent care at least is maybe less than $300.
Yeah.
Right. So that's why those helping create the right access. Because we can't change all the costs, right? We can't change
No, but you
employee
can get
costs,
them
but
to
we
the
can
right level of
get
care,
them to the
right?
right spot.
And it should help the ERs, by the way, too, where
Right.
where you've got an aging. The other thing that's happening, you know this better than anyone, is you have an aging population. You have sicker people. I talk to my old partners now, and it's like,
The complexity here is
how are you doing? And they're like, good. But remember the good old days where you would have one or two really sick people, and then you'd have this big population of kind of, healthy people that are
Right.
coming in for it. It's now just sick people.
sick people. And we're seeing that in the hospital post-pandemic. We took a lot of surgeries out of the hospitals during
Yeah.
the pandemic, and we tried to figure out how to do them outpatient, which that was always a trend
Yeah.
for years, but the pandemic sped that up. So we had to reshape our Boise hospital's inpatient beds. So we have very little inpatient orthopedics now. We had a whole floor of orthopedics before, 30-some beds.
Well, they're sending people home like
Same day. You
you go have a hip, and you're like, hey.
Yeah, it's incredible. But
Isn't
it's
it-
also
it's
so the
advancement in
hospitals are
technology,
becoming
right?
very much high acuity centers.
Yeah.
I mean, I don't doubt in the near future you're hardly going to have a general medical surgical floor
Yeah.
bed. It's all going to be high acuity, critical care, telemetry, step down.
How are we doing demographically here with our aging population? And do you worry? I mean, it's funny because you heard a lot about it like 15 years ago. Everyone was worried about, hey, the boomers and the demographics, and hey, here it's coming. And I think the pandemic hit and it sucked up all the oxygen. And then there's just all this other stuff but I was actually thinking the other day, I'm like, it's been, or we're getting closer. And if you look at those curves, it happens.
We're experiencing it.
Is it happening
Absolutely.
already?
There's a few things that are happening in the valley. One, we have the aging demographic. That's also who's moving into the valley.
Yeah.
And it's interesting, kind of that 55 to 65, fairly well-off individual. They're needing lots of because they're active.
Yeah.
Knees, spine surgeries, PTs. So we have that kind of population.
I am that demographic.
Right. We like to have fun. Right. We're out mountain biking. We're
It ain't the same anymore.
horseback riding, ATVs, whatever it is. But they have a pretty high utilization
Yeah.
of healthcare. So that's one population. Then that's right when you get into Medicare age, they're still just as active.
Yeah.
And so I know for both health systems, but speaking for ours, we're seeing a shift from that commercial age group into more of a Medicare age group, which also has impacts because that reimbursement rate is so different.
Oh, I had never thought of that. So
that's
now-
occurring. And
yeah.
at the same time, you have, and I get why, you have, this physician-owned surgery centers and some of those centers pulling out that commercial population. So the hospitals are trying to really figure out how do we manage that. And, for us, we did open up our own surgery center that is an ASC, that is reimbursed at an ASC level versus a hospital-based level. And I think that's key as we keep thinking about that cost structure. But with the demographic changes, we got to keep adjusting for that,
Yeah.
and figure out how do we come around it, because it is changing. And then you look at our birth rates in the valley; the rates are are actually decreasing, but the number's pretty flat. So you'd think with all this population growth, we should have a lot more babies coming in. There's
Yeah.
not a lot more babies because
people
of
aren't
that.
People aren't making babies like they did.
No, and so we have to keep adapting. What type of services do we need? So we need more nephrology, urology, pulmonary medicine to help with an aging population.
How has talk a little bit about physician recruitment in the different specialties where you see some of the greatest needs or the hardest specialties to recruit?
It's really primary care.
Is it?
We've done pretty good with most specialties. The one specialty would be neurology. That's been a
Yeah.
tough one here
Always has
and
been.
nationally.
Yeah.
I mean, a lot of organizations looking to J1s or some other way to
Yeah.
bring in some out-of-country experience. Outside of that, we've done fairly well. Sometimes it takes a while, but primary care is a national problem, but here especially.
Yeah.
And so that's why that GME program we talked about is important. I don't want to dive too deep into the women's health topic, right? There's a lot to unpack
Yeah.
there, but OB and
Yeah.
women's health is a big problem
Yeah.
for the state to ensure we have that access. And we got to keep working on that one to try and get us to a point that we can
Yeah, and
ensure
it's-
access to care there.
Yeah. And it's probably a whole episode because
Yeah.
just so much going on with it. And go back to the primary care thing. Is there anything like people listening to this should know or could help with? Because ultimately that becomes the problem. And by the way, we got the CEO of the largest or second largest hospital here in the valley here. Can you imagine if we were talking to anyone in rural-ish Idaho? Like,
Right.
don't even take rural, but like if you just go that next tier down,
Yeah.
they got to be just, really hurting for
Really
primary care.
struggling. Yeah. Support from the state's always important. Think
Yeah.
about it if you're a family doctor, though. You come out, you have debt, several $100,000, and those physicians don't make what a specialist makes.
Yeah.
Got young families, and so they're trying to figure out, where do I go and how do I make that happen? So, and then you come to Boise, who used to have a low cost of living.
Yeah.
So it made it even easier to bring in these primary care doctors.
Man, it used to be so easy to recruit here.
So much
honestly,
easier.
we'd
didn't have
interview
nursing
every year for our
problems, we
groups.
didn't- yeah.
And they'd come here, and wherever they came from, they're like, oh,
Yeah.
great. You have the outdoors, you have the culture, you have the river, you have this heritage family, everything you have here. And then it's like, was it inexpensive to buy a house? Mm-hmm. And now it's like not. It's
not.
You're on the other end of it. And
Yeah.
it's like,
We've had to create housing stipend programs
Yeah.
for nursing and physicians. I mean, even specialists who make very good incomes come to the Valley and like, this is incredible for what I have to pay for a house versus even other parts of the country now.
Yeah.
So it's a new dynamic we're dealing with. When we recruit here, it's people that want to be here or used to live here.
Yeah.
And so, but the primary care investment, we just can't stop. We have some pretty big, bold goals at ALS to recruit into the Valley and retain for sure any of the ones coming out of residency because our local residents are incredible and we can't lose one.
Wow.
So,
hey, I have a couple other. I just looked down. And it's 10:43 already. AI. Mm-hmm. So I'm going to tell you a quick story, and then I'm going to ask you because I have a friend of mine who's brilliant. His name's Fahim Rahim, and he's a nephrologist over in Pocatello.
Okay.
Incredible story because he comes over to America, him and his brother Nahim Rahim, and they have like a few $100. They land in New York, and it's a true story. They look at a map saying, where don't we have any nephrologists? And this was like 25 years ago. Mm-hmm. And the place in the country 25 years ago with the fewest and with the largest encampment area and no nephrologist was Pocatello. So they come to Pocatello and they set up their life. So, and they're incredible human beings, entrepreneurs. But he calls me a year and a half ago and he's like, I have got this company I'm starting is the next big thing. And he talked about, he's doing a AI company for nephrologists. So pretty tying down, but I want to get there.
Yeah.
And I'm like, I barely know how to spell AI. So I'm just like, tell me more about this. But it uses, so his technology, it's now launching now. Nephrolytics is the name of the company. But it uses 3 forms of AI. So the first one, and this has been in development for years, but first one is you walk into the room, the physician has been, lets the patient know, hey, I'm going to be recording our conversation. And then they're pretty good about knowing that but this is normal. The one thing that you don't realize is when you walk into a room, because you're already thinking this way, history of present illness, you have to ask all these questions anyway. So then they ask the questions, the recorder is catching it all, it's auto charting the entire interaction with the patient. So then that's done so that when you go to chart, that in theory is all done already. The second part of the AI is because nephrology is so data driven. What are your labs doing? How are they compared to your last labs as they track your creatinine and all the other stuff? That's been done before the visit. So that all auto uploads into the chart and gives a big giant summary note that's already written of, hey, Mrs. Jones has this is what's happening with her. And so that's done.
Yep.
And then the third thing, which is like blew my mind, is now it says, okay, Mrs. Jones has all this stuff. This history has been loaded. Here's what her new thing is. It takes in what's happening with her now, all the vital signs and everything. Here is the treatment recommendations for Mrs. Jones based on all of the data. And man, I'm like, this is cool.
Amazing. Yeah.
So are you seeing kind of similar things on all fronts?
Absolutely.
AI?
Absolutely. So we use a program called DAX. We've been piloting here locally.
DAX?
It's called DAX, DAXE.
Okay.
And basically it's the same thing, active listening while the physician, we've been trying it with our primary care doctors, listens, does the same, creates the note, doctor can go in, do a quick summary. We think providers what we're seeing is anywhere from about 3 patients more per day, or it takes care of their pillow time at night, we call it, right? After you're closed for the day, taking away those 2 hours of documentation. So that's working amazing. And we're rolling that out through the whole group. We've used AI for a couple years now on imaging studies because as you come in for whatever study it may be for a certain purpose, the radiologist tries to check for anything, but they're moving through hundreds of images. So the AI technology basically scans through every image, and if something flags, it sends it back to the radiologist to look at it. typically looking for cancers or those types of things. And then if they
the,
see
the
it,
example is you come in because you think you broke your rib. I shoot a chest X-ray and I go look and say, oh, you didn't break your rib, or you did break your rib.
Right.
That chest X-ray has all the other data of, oh, there's a nodule in the left upper lobe or whatever.
scans, X-rays.
Oh wow, that's
that.
cool.
So then that way, at least somebody can make an informed decision. Do they want to seek additional care? And so that's amazing technology, because then they're putting the power back to the patient and the provider, and they may not have known or caught things. So that's amazing technology. On the inpatient side, we're going to start testing it the same way with nurses, because think how much time nurses spend documenting versus caring for their patients at the bedside. And so if that active listening technology can be used to get them back to the bedside, it'd just be incredible.
Do you want to know what I love more about it? Because old guy thing again, like there was a dramatic change. So we used to have like training, like for all the new docs, like, hey, grab a stool, sit down, scooch up to the patient, like look them in the eye, have a conversation with them, right? And then you had all of a sudden this change where you would wheel in a cart, right? And you went from, hey Dave, I'm here to take care of you, to
looking at the computer.
Hey, when was the last time you were in? And it just changed everything. So the one thing that Fahim was saying is the nice thing about this is now you're back to engaging. I mean, think about this. You're now back to talking to a patient again. So it's awesome.
Awesome technology. Yeah. And the other
how much do you think it's going to save? If you guys have to know this because you're so smart, is as you get through this FTE crunch and kind of the future of medicine, has anyone done studies on like the efficiencies and what it may mean to the overall cost of care?
I think it's cost of care and it's staffing.
Yeah.
Because we're all struggling with staffing. So it's both being more effective, more efficient with our time. So we need less physicians, less nurses to fill the future need, because as that aging population, we're going to need more care. So that's going to help, I think, adjust for some of that. I don't know the numbers off the top of my head, but absolutely,
it is better.
Absolutely better. The other thing that I think is pretty exciting is so much of the healthcare cost is in billing and all that back-end process work too. And AI should be able to help automate the vast majority of all that coding, documentation, versus having individuals have to scrub charts, figure out how to code it, and it should be more accurate too, as it flows right out the system. And then there's just a review audit process. So I'm excited about that to reduce that cost as well, just so we can help streamline that process in the future.
That's great.
A dream would be the payers do the same thing. We actually collaborate. It's a really nice process instead of the back and forth that can occur.
Right.
But pipe dreams.
Yeah. That layer, that tension, that healthy tension, that whatever you want to call it is, it's always been part of it, but ever changing, right?
Ever changing. Yeah.
Yeah. How's that been working for Trinity?
People say all the time, you gotta hate working for a large national company. Trinity is not that way. If you ever get the chance to sit down with the senior leadership at Trinity, and we're based out of Michigan, just outside of Detroit and Livonia. We're a Catholic-based, faith-based organization, and salt of the earth, just incredible people.
So I'll tell you a quick story. I got to go there with Odette.
Oh, did you? Okay.
One time. So we went back and met with their top brass and went into the conference room and very nice people. The one negative for them is they were all Detroit baseball fans, and it was like at the start of the season, and they'd already lost all their mojo, right?
Yeah, and they're pretty proud back there with their sports teams.
Teams. But we get in there and we sit down, and like the first thing they said was, "Who wants to take a mission minute?" And I wasn't ready for that. And what was cool about it is I'm trying to remember the name of the CEO, but very impressive, very impressive.
Mike Zabowski.
Yeah, Mike. But he looked at us and said, hey, would one of you like to do the mission minute today? And by sheer luck, that morning was the Meridian Mayor's prayer breakfast. And I gave the thought there. So I'm like,
you're perfect.
Polished it off. And he was impressed, but I didn't ever tell him. It's just because I just did it this morning. Anyway, it was really cool. It was awesome that the first 15 minutes of that meeting was talking about patient care, talking about why we do this, talking about, hey, this is service-based. It was really, I'm not just, we walked out of there and I'm like, whoa.
Yeah, just genuine.
I mean, we're going in, and there's no reason that could have been part of the meeting. And we spent the first 15 minutes kind of level setting on why we're doing what we do.
Absolutely.
I was blown away.
You meet with our teams here locally, you'll get that sense.
Yeah.
Right? That's who we are. That's our passion, our mission. But when you have that at the home office team, the system office team, it penetrates all the work that we do and how we make decisions. And when we're making tough decisions, we call it discernment process, and
Yeah.
we look at it from all angles, not just financial. What's it mean for our communities? And so to have that support from them is incredible. And to have a national presence, we have over 100 hospitals nationally. So I can pick up the phone, talk to a friend in New York or Florida and say, hey, I'm dealing with this problem. You have any ideas? And we get together as a CEO team. There's 12 of us that report up into the system office. Every 2 weeks, we get together 4 to 6 times a year in person, spend several days together just brainstorming what's happening across the country and how can we bring that back to our local markets to help make improvements and investment. And so that's unique and special, and we're all aligned. I mean, you can go to our Florida hospitals and you'd experience the same type of culture and passion, which is
That's
pretty
awesome.
cool.
And then as a consumer of healthcare here with you guys, I mean, I've had what great experiences. I've had some
Incredible clinicians.
some heart stuff going on for the last few years, and man, it's been great.
Yeah.
It's been the highest quality care. We're really blessed, aren't we, Dave?
Very blessed. For
We're-
our size
we're-
community.
We're done for our size community. Man, we're blessed.
Yeah. Well, and as you know, you draw that circle around Boise. We're one of
Yeah.
the most remote communities in the country.
Yep.
Especially in healthcare as it relates to how far do I have to get
We're
to
on
an
an island.
academic center. And we are the most remote. And so, St. Al's has been committed over the last decade to really bringing in those specialists so you don't have to go to Utah. And we have them.
Yeah.
And they love being here. And they're part of the community. And we don't want to ever have to use them. But to know they're there and we have that backstop is special.
Well, hey, buddy, you were a tremendous leader.
Yeah.
And they're lucky to have you, and it's going to be wonderful to watch you shape healthcare here. And we're lucky that a local kid
Yeah.
is
Great opportunity.
passionate here in your own community to be the CEO of a giant organization. How many employees do you have here?
So between here and our Fresno hospital, about 9,000,
Yeah.
7,500 here locally.
Wow, 7,500. Well, we're in good hands.
Thank you.
Thank you
Thanks.
for what you do, and we've wanted to have you on since you took over to just talk healthcare, and this was good, and I just really appreciate you, man.
Yeah.
Look
Thank
forward
you.
to
Thanks for
watching
the
you.
opportunity.
Thanks.
Good to see
Thanks,
you.
everybody.